Okay, I'm just gonna wait a couple seconds here for folks to join us. Okay, let's go ahead and get started. Well, hello everyone, and welcome to this virtual pharmacy school fair workshop. I'm Danielle Subskirkland from AACP, and I'll be moderating this session. We'll get started with today's session, Combating Deadly Infections, the role of the infectious disease pharmacist, in just a moment. But first, just a few housekeeping items. Although you'll be muted the entirety of the webinar, please feel free to ask questions in the Q&A window throughout the webinar. We have saved some time after the presentation to address any of those questions. If there are any questions we don't get to, the speakers will be available in their booths during the expo hours from 5 p.m. to 7 p.m. Eastern. So we highly encourage you to visit their virtual booth at that time. Additionally, this presentation will be recorded and available immediately afterward under the Sessions tab. Now I will turn it over to our speaker to go ahead and get started.
Thanks, Danielle. Well, for those of you who are here, thank you for joining me in this session. My name is Dr. Joshua Garcia. I'm an infectious disease pharmacist. I did my training at Philadelphia College of Pharmacy and then 2 years of residency at UCSF, where I learned how to become an infectious disease pharmacist. And currently, I'm a faculty member and a teacher at Marshall V. Ketchum University down in Fullerton, California. So, like Danielle said, if you're interested, please check out our booth. We can give you more information about our program and whatnot. But I'm here to talk to you guys about the clinical specialty of infectious disease pharmacists and what we are doing to really help our healthcare system combat resistance and deadly infections. So the things that I'm going to go over today in terms of this talk, we're going to go over antibiotic resistance. Essentially, what is it? Why is it a problem? How did it get this bad? The role of the infectious disease pharmacist. And if I've captured your interest in becoming an infectious disease pharmacist, how do you do that? How do you get there? So let's go on and get started. So first, we're going to talk about this growing resistance problem. And for some of you, if you've taken microbiology or any sort of cellular biology, you're going to learn that eventually we have a plethora of microorganisms that have existed on this earth for quite a bit of time. And unfortunately, they have been the cause of many infections and many deaths throughout human history. That being said, when we have developed antibiotics, they've become a medical marvel, allowing for humans to live for longer and longer and longer, have better quality of life. But that being said, because we are combating living organisms, they oftentimes will try their best to evolve and adapt and continue to survive themselves. And that is what we call antibiotic resistance. And while we have developed antibiotics to help cure our patients, these bacteria become stronger and stronger and stronger to the point where now we actually have some bacteria that are resistant to all of our known bacteria or our known antibiotics. And so what is resistance? And so let me give you guys an example, and let me just say that let's say that we have some bacteria in this petri dish. We have some purple bacteria that represent normal bacteria. There's no resistance gene in there. But then a few red colonies that basically are more resistant and can fight off antibiotics and our infections. So that being said, when we have all of our organisms kind of milling in a petri dish, they're competing for resources. They're competing for food, nutrients, and whatnot. And so it kind of is a little bit of a mix. Now, if we introduce an antibiotic, that antibiotic will kill off all of the organisms without a resistance gene, leaving mostly those that are resistant left. And because there's no more competition, those resistant organisms become the predominant species. And so this is what happens in our human bodies when we give too many antibiotics. Eventually, we kill off weaker bacteria, leaving only the strongest to survive. And in our patients, that means that sometimes we can get some infections that cannot be treated by any known antibiotic. So how serious is this problem? So I have some quotes here from the UK chief medical officers from back in 2015 and 2020. You can see that modern medicine as we know it, if we don't halt this rise of resistance, will be finished, and antimicrobial resistance could kill us before the climate crisis does. So very scary stuff. So here you can see in terms of the number of deaths caused by different disease states, AMR stands for antimicrobial resistance. You can see other ones like cancer, measles, accidents, diarrheal diseases. What we've projected is that if we don't do something about this antibiotic resistance problem, by the year 2050, that number of deaths that are caused by antibiotic resistance could skyrocket even higher than cancer deaths or anything else that we currently see. So something that we really have to work on. That's kind of the future. So where are we now? So the CDC typically comes out with some estimates for how bad antibiotic resistance is, and you can see here that this was published back in 2019, I believe. So they're due for another update. But back in 2019, you could see we had almost 3 million infections that were due to antibiotic resistance bacteria, and of those infections, about 36,000 deaths. We can also see here that there's an infection known as Clostridioides difficile, which is an infection specifically due to using too many antibiotics, that those cases are on the rise as well. Some of the big players, some of the big super bugs that we're starting to see cause problems in our healthcare system today. If you guys become pharmacists in the future or professionals in general, you will deal with some of these organisms. And so things like carbapenem-resistant Acinetobacter, Candida auris, Clostridioides difficile, Neisseria gonorrhoeae, carbapenem-resistant Enterobacteriaceae. These are very long names, things that I deal with on a daily basis. And again, these are some of our super bugs that are emerging. And unfortunately, some people they get infected with these pathogens, and we have very limited antibiotics to be able to treat them. If we don't have antibiotics to treat them, unfortunately, their outcomes can be not so great. And so, how did it really get this bad? To give you guys a little bit of a history, really, there's three reasons why we have seen so much antibiotic resistance over the past few years. They are mainly due to these three reasons: is overall overuse of antibiotics, a lack of new antibiotic development, and then rapidly adaptive bacteria. So we're going to talk about each of those in a second. So, in general, the more we use antibiotics, the more we kill off those weak organisms, and the more we get the more resistant ones. We typically see antibiotics used a lot in the healthcare system because our patients are very, very sick and we need to make them better. So we often see them overused in the healthcare system. About one third of antibiotics used in the hospital are not appropriate or too broad in some way, shape, or form. We often see overuse in the community. You go to your dentist's office, you go to your doctor's office, you get a prescription of antibiotics to prevent infections. What we have found is that over time, although these antibiotics are meant to help us, again, we're overusing them, and we see a lot of resistance come from that. And then finally, we also see overuse in animals, agriculture, and livestock. Oftentimes in agriculture, we will give antibiotics to chickens, cows, other meats in order to prevent infections, and they actually will grow bigger. The problem with that is that we're exposing them to antibiotics. They can harbor resistant bacteria, which then go into you as you are eating it. In addition to that, these animals will often have poop and pee and urinary feces that will eventually make its way into the soil, and then that grows our crops, and then we have antibiotic resistant vegetation as well. So again, a lot of overuse of antibiotics is one reason why it's gotten so bad. Bacteria are also really smart. They're very adaptive and become resistant over time. This chart here on your right shows the antibiotics and the year that they were developed. And then on the right-hand side of the column shows when we started to see resistance genes to those antibiotics develop. And so for some medications, right, like vancomycin here was developed in 1958. Luckily, we didn't see resistance to that until like about 30 years later. But unfortunately, we can see, especially some of our newer medication that we've developed, like daptomycin and ceftazidime avibactam, sometimes we see resistance come about only a year or sometimes even within the year that they're developed. So our bacteria are getting smarter faster. There are a few different ways that organisms can become resistant to our antibiotics. Sometimes they can produce enzymes that destroy our antibiotics before they can even get to them. Sometimes they can produce pumps that pump out antibiotics so that they don't stay in the organism. Sometimes they will reduce the channels that allow for antibiotics to enter. And then sometimes mutations will change the target site of our antibiotics, rendering them completely useless overall. And then finally, the third thing is that there's been a lack of antibiotic development in the past few decades. And so here you can see a chart of essentially how many antibiotics have been developed. And you can see there's really been a discovery void in the last like 20 or 30 years. And that reason is because normally when you develop a medication, it takes years and years and years and much, much money to be able to develop that antibiotic. Now, if this is a normal hypertension medication or medication for your blood sugars, normally that medication gets developed and we say, go ahead, use it on everyone. But for antibiotics, unfortunately, when we develop a new one, because we don't want resistance to generate, normally an antibiotic is made and it sits on the shelf because we say, hold it, don't use it until we need it. So that's not a whole lot of incentive for drug companies to make new antibiotics. And so many of them, you can see 78% of major companies have actually scaled back antibiotic research. And so, what are we doing to try to combat this resistance? And so, in order to incentivize some drug companies to make more antibiotics, there have been some public and private grants that have come about in order to say, hey, I know you're probably going to develop this antibiotic and it's going to sit on the shelf, but we still want to incentivize you. We will still pay you for developing that antibiotic for the good of all mankind. In addition to that, there are also some antibiotic-free livestock practices that have come about. If you guys go to the grocery store and you see either chicken or beef that says antibiotic free, those were raised with antibiotic resistance in mind to prevent this from getting worse and worse. And then finally, the Joint Commission, which is kind of the accrediting body for many hospitals, have developed antimicrobial stewardship programs. And I'm going to talk about that a lot because that is where pharmacists have really made our mark in terms of helping the antibiotics resistance movement. And so, again, newest growing role for pharmacists, specifically infectious disease pharmacists. And so, this is where I'm going to talk about what we can do as pharmacists to help with this kind of medical problem. And so, an infectious disease pharmacist is essentially a pharmacist with specialty training, specifically in understanding infections and antibiotics and how to use them. So in addition to all of the normal pharmacist knowledge we have, we spend additional time to train to learn about antibiotics, antifungals, antiparasitics, and antivirals in order to help make our patients better, but also to reduce the amount of unnecessary antibiotics to combat antibiotic resistance. So this is a picture of myself and my cohort at UCSF, some residents from the past, so it's kind of a nice little timeline. But I'm going to talk about these areas of infectious disease pharmacist practice because these are all the different areas that if you become an infectious disease specialist, you can go into practice in. And so antimicrobial stewardship programs, inpatient ID consult, clinical outpatient ID, academic ID pharmacist, and antimicrobial development and education. So we're going to start with antimicrobial stewardship programs. And so antimicrobial stewardship programs are essentially mandated programs in the hospital that are essentially dedicated to having pharmacists and physicians reduce the number of unnecessary antibiotics to reduce costs for hospitals and reduce antibiotic resistance. And so the great thing is that every hospital in the United States has to have one of these programs. And in each program, there has to be at least one infectious disease physician, one infectious disease pharmacist. So quite a bit of job security on our end. But what do we really do? And so in antimicrobial stewardship programs, I like to say that I'm kind of like the antibiotic police of the hospital. I spend my day looking at every patient in the hospital that has antibiotics. And essentially, I'm scrolling through and screening through each one of them to see if the antibiotics are appropriate or not. And if they are not appropriate, I'm contacting the physician who ordered that antibiotic and having a conversation with them to discuss, like, hey, I know that your patient is quite sick. I know that you started this antibiotic for them, but it has a lot of side effects. It's creating a lot of resistance. So how about we use this alternative one instead? So, like I said, I end up spending a lot of time talking to physicians, talking to nurses, trying to scale back antibiotics in some critically ill patients. Again, the hope is that if I am able to reduce the number of big, broad spectrum antibiotics down to more narrow ones or take them off entirely, we can not only reduce costs for the hospital, but we can also reduce the amount of antibiotic resistance that occurs in our hospital and in our community overall. Another area that infectious disease pharmacists can practice is inpatient clinical ID consult. And so these are patients that have kind of out of the ordinary infections, infections that are either due to organisms that you don't see very often, like certain funguses or resistant bacteria, in which myself, the ID pharmacist, along with the medical specialist, the infectious disease physician, the fellows and the residents, we come together, we'll round on each patient, i.e., talking about each one and developing a treatment plan for them. Pharmacists are huge, huge, huge importance in terms of these roles. because we come in with medication knowledge that the physicians don't, and we can help optimize patient care in this case. One example was when one of our patients, back when I was a resident, had about 5 different concomitant infections, and with that had tuberculosis medications, HIV medications, antifungals, antivirals, antibacterials, all of which have major drug-drug interactions with each other. And because of this, I remember the team was going over the patient, stopped what they were doing, and looked at me and said, "Josh, can you handle all of these drug-drug interactions?" I'm like, "Yeah, give me about 20 minutes and I'll be able to figure out what we should do for you." So again, really collaborative environment, and you get to work on some very unique, interesting cases. Many ID pharmacists are now working in outpatient clinics. There are some infections that, although serious, have become very manageable for patients out at home so that they don't have to live at the hospital. They can manage things like their hepatitis C, their HIV, at home. And so pharmacists in these roles will essentially act as primary caregivers to these patients, and we will manage their hepatitis C, their HIV. We'll help them with insurance problems. We'll teach them if they're having adherence issues or having side effects, how to mitigate those. So these pharmacists in these roles get to talk to their patients quite a bit. And we get to kind of have a growing relationship with them as we see them on a week to week or month to month basis. Um, Other pharmacists will go into academia because, just like myself, we love teaching, we love mentoring students. And part of every pharmacist training is learning how to manage infections. And so, my role as an academic pharmacist is that at Marshall B. Ketchum University, during the students' third year, I teach them everything and anything they need to know about how to treat pneumonias, how to treat skin infections, how to treat COVID. Because, again, I'm training pharmacists to do my job, to be able to be those antibiotic stewards to help reduce the use of unnecessary antibiotics and reduce resistance. So, again, a lot of research and educational responsibilities for this. And for many academia pharmacists, we still get the best of both worlds. I get to teach the students about 2 to 3 days out of the week. And then on my additional days, in fact, that's one of my days today. As you can see, I'm in scrubs. I get to be at the hospital and still get to do my infectious disease pharmacist roles. Some infectious disease pharmacists will work in the pharmaceutical industry, helping to develop and get new antibiotics approved to be used. Because again, antibiotic resistance has a few different arms, one of them being overuse of antibiotics, and the other being we're not developing enough of them. And so, that being said, within the pharmaceutical industry, there's a wide range of roles. Some of them within infectious disease include developing new antibiotics or getting them approved to be used by physicians and pharmacists across the world. Now, again, if I've captured any of your interest in terms of infectious disease pharmacy as a specialty, I wanted to talk about how you become an infectious disease pharmacist and what that training looks like. And so I love this roadmap that AACP has created, but a roadmap to pharmacy, and I've inserted here, as you can see, infectious disease pharmacy. So every pharmacy student will go through your pre-pharmacy study, which is what I assume most of you are going through now. You'll apply to pharmacy school, and then once you get into a pharmacy school, that goes for about 3 to 4 years, depending on which program you're choosing. After you finish the PharmD, you'll complete your NAPLEX examination and your individual state law examination, your licensure exams, and then you are fully fleshed out pharmacist. Now, most infectious disease pharmacists will go on to do a little bit more training to get that specialized knowledge. So, for most of us, we will do a 1 or 2 year residency. Typically, a first year residency is kind of a general residency, a little bit of cardiology, a little bit of oncology, a little bit of infectious disease. And then, if you choose to go on and specialize in your training, you'll do a PGY2 residency, which is what I did. If you are more interested in the drug industry and development program, you'll go into the fellowship programs. And then afterwards, there's also additional exams and board certification that you can do if you want to become even more specialized. Now, for infectious disease pharmacists, again, as I mentioned before, you'll do a first year general residency and then a second year specialty residency in infectious disease. As I mentioned before, after I graduated from Philadelphia College of Pharmacy, I went on to do a first year general residency at UCSF, and I stayed on to do my second year specialty residency there as well. Again, we mentioned infectious disease fellowships, and then finally on board certifications, there are really two that currently exist for pharmacists: the general ID board certification, or the BCIDP, and then if you are more HIV focused, there is the AAHIVP pharmacist certification that many of them do as well. And then finally, I wanted to talk about that this is a growing field of specialty. If you guys are coming into pharmacy school, it's amazing what I think the opportunities will be like by the time you graduate. As you can see, look at the number of infectious disease residency programs that have grown over the last few years. So back in 2007, there were only 22 PGY2 residency programs in the country. And you can see this is data as of 2023. It's actually a little bit more now, but that has skyrocketed to about 138. And that is because the hospitals have noted how much we need infectious disease pharmacists, and so we need more training opportunities for them. The graph on the right shows the number of different specialties that we have, and you can see some of them have been around for quite a bit of time. Infectious disease here is in gray. And so you can see since 2018 was when it was officially recognized as a board specialty. But then since then, even though it's a little bit newer, has skyrocketed in terms of popularity. So back in 2020, much more popular. And again, this is cut off at 2020. I guarantee you after COVID, there was actually even more spikes in interest in infectious disease. So again, in conclusion, antibiotic resistance, one of the most pressing problems that is affecting our healthcare system today. But us as infectious disease pharmacists are on the front lines of combating that, and we can do that in a number of different ways. Again, and if you are at all interested in infectious disease, this is an amazing opportunity for you to go into as you start your pharmacy journeys. And with that, again, I wanted to make sure that I saved a little bit of time just in case anyone had any questions. But that being said, I appreciate your time. And if anyone has any questions, I'm happy to answer them here as well.
Awesome. Thank you so much. This is such a great presentation. I learned a lot, and we do have one question in the Q&A box. So, how do you stay abreast of developing resistance? Literature searches, professional associations, anything like that?
Yeah, great question. So, that being said, resistance is occurring all the time. I would say for myself, because when you're in practice, it's hard to balance keeping on top of everything while doing your actual pharmacist responsibilities. I subscribe to a few different academic journals. So that being said, New England Journal of Medicine and JAMA are like two major ones that just kind of come to mind in general for all different medical updates. But I also subscribe to CID, Clinical Infectious Diseases Journal. So that journal normally comes out with different articles and journals that kind of talk about not only just resistance, but new developments within the infectious disease spheres as well. So I subscribe to all of those. There's also one which is a little less clinical. Um, it's called Contagion. Contagion is, I think, a little bit easier to do, like quick reads. The articles that are written in there are written by clinicians like myself. I've published in there a few times, but they are less academic, but more kind of updates for the ongoing ID clinician. So Contagion is another one that I would recommend if you wanted to stay abreast of antibiotic resistance. It's very helpful.
Awesome. Thank you. We do still have a few minutes, so please feel free to continue putting questions into the Q&A. We have one more. So I've heard of fellowships. What are they exactly, and what goes on during those fellowships?
Yeah, great question. So, some people may have heard of fellowships from the medical doctor arena. And so, if you are a physician, typically physicians go through medical school, they go through a few years of residency, and then if they want to even further specialize, they will go into fellowships, right? Pharmacy is a little different. I don't know why our naming convention is a little separate. For us, fellowships are typically associated with working for the pharmaceutical industry. And so a fellow for a pharmaceutical industry is essentially most of the times a new grad pharmacist who is doing some postgraduate training or fellowship for someone like Merck or Genentech, one of the pharmaceutical companies. And then to the question of like, what do you guys do in there? It really does depend because for every individual role that someone can work at in the pharmaceutical industry, they have a fellowship for. So there are some fellowships in drug research and development. And so those fellows for that year or two will spend their time working in drug development and learning how to be a pharmacist within that realm. There are some fellowships that are more specifically looking at regulatory affairs. And so those pharmacists are essentially in charge or help a medication go through the phase one, two, and three trials for FDA approval. So pharmacists as fellows there kind of learn the ins and outs there so that when they finish they can do that job. So I should let you know that fellowship is again another postgraduate training opportunity. You're typically not making your full salary, but in that time you are getting additional training to learn how to do that job. Many times industries or pharmaceutical industries will hire their fellows afterwards, so it's kind of thought to be kind of a step into the industry. But yeah, that's a little bit of nomenclature difference. For whatever reason, doctors, their fellowship is specialty. Ours talks completely different about the industry. Our specialty is a second year residency or PGY2.
Do you mind going over what a residency is as well?
Fantastic. Yeah. And I apologize. I kind of breezed through that. So for those of you that are interested, after you graduate from pharmacy school, if you want additional training, you can do a residency. And so fellowship is more postgraduate training for the industry. If you want to work in a hospital or work in a clinical specialty, that is what a residency is. And so essentially you are again a fully licensed pharmacist. But during that entire year, you are still going through rotations, but you were doing it under the supervision of your residency program and other pharmacists. So, as a pharmacist, when I was in residency, I could still verify medications, I could still do everything. But I rotated through different parts of the hospital for about 6 weeks at a time. And during there, I was again gaining clinical knowledge, learning how to be a clinical pharmacist and stand on my own. Very similarly, you're not making the full salary during that time. But again, you're trading off the full salary for a year so that you can hopefully, again, gain some additional clinical knowledge, be more marketable. And many times hospitals will hire their residents afterwards. So it's, again, kind of thought to be a step into the clinical spaces.
Amazing. We have a few more minutes left, so please put any questions you have. I actually just thought of another question because I know you mentioned fellowships, residencies, and on the one slide you also had certifications. Where does, I guess timeline wise, where does that fit in?
Yeah, great question. And I'll see, can I go back? Yeah, so for the board certifications, so BPS, the Board of Pharmacy Specialties, does all of the board certifications. And so in terms of timing, it kind of depends on which board certification you are going for. So for instance, if I wanted to do the board certified infectious disease pharmacist specialty, I have to finish both a PGY1, a PGY2 in infectious disease, and then it qualifies me to take the board certification exam for infectious disease. If you don't do an infectious disease residency, I believe the other qualification is that you work within infectious disease for 5 years, and I think that qualifies you. There are other board certifications that are just like generalist board certifications. And so for me, at one point in time, I actually had the generalist board certification, and I was able to take that after my PGY1 general residency. So in the middle of my PGY2, I had that generalist board certification, and then after PGY2, you can take the infectious disease one. So very similar for HIV. After you finish your HIV training, then you can take that board certification exam.
Super helpful. And I did want to plug real quick that the Board of Pharmacy Specialties will be at the expo tomorrow. If any of you want
Oh,
to ask more questions about the infectious disease pharmacist certification or any others. There is another question here. How would you balance work and school while in residency? And do you need letters of recommendations for residency?
yeah, great question. So, and I think I understand it. So, to answer that last part first, yes. So the residency application process, similar, a little bit different to the FarmCast application system. You're going to put all of your information in. You're going to send your transcripts from pharmacy school in, and they will require that you get letters of recommendations as well. Most of the times, they will require that at least one of your letter writers is from one of your clinical rotations while in pharmacy school to get a gauge of your clinical ability. But many people also ask their faculty members or maybe another faculty or preceptor that they did research with. That typically like spans your three letters of recommendation. And then the second question was asking about like work-life balance. While was Daniel, was it within residency or
Yes, within residency.
yeah. So I will tell you that residency is very well, I think one time I heard someone say that residency gives you about 3 to 5 years of experience. 1 year of residency gives you about 3 to 5 years of work experience. And I will attest that I think the reason why it gives you 3 to 5 years of work experience is because it feels like they crushed 3 to 5 years into that 1 year, right? So I just want to tell everyone who is interested in residency, I think it was the most beneficial thing that could have happened to me for my career and my professional development. But it was probably the hardest year of my life, even harder than pharmacy school itself. And that's really because I think that on top of your clinical responsibilities, your teaching responsibilities, your research responsibilities, you're also still staffing in the pharmacy. I think that I really learned how to stretch and um, tip the scales on that work-life balance as much as I could, right? But again, I would say that I fully support it because during those years I gained so much confidence and so much knowledge that really after 1 year I felt like I was a 5 year experienced pharmacist and could go anywhere.
Awesome. Thank you so much. Um, Well, with that, we're going to end the session. We're right at time. So thank you all for attending this session. Like I said in the introduction, if you have any questions that we could not address today, please feel free to visit the Marshall B. Ketchum University booth during the expo hours from 5 p.m. to 7 p.m. Eastern. Please join me in thanking our speaker today for their time and insights, and please enjoy the rest of the fair. Thank you, everyone.
Thank you, everyone.